Before we dive in, a quick request. Hit subscribe so you never miss our exam smart episodes, tap like if this helps your revision, and drop your next topic suggestion in the comments. Alright, today's focus is hypertension, a perennial favorite in community medicine Viva. Dr. Joshi, to start at first principles, how do we define hypertension and how is blood pressure classified for exams?
Great opener. For exams, quote the 7th report of the Joint National Committee, JNC 7. It defines hypertension based on the average of 2 or more properly taken blood pressure measurements at 2 or more visits. Classification by JNC 7 goes like this. Normal is systolic BP less than 120 millimeters of mercury and diastolic BP less than 80. Pre-hypertension is systolic BP 120 to 139 or diastolic BP 80 to 89. Stage 1 is systolic BP 140 to 159 or diastolic BP 90 to 99. Stage 2 is systolic BP 160 or more or diastolic BP 100 or more. WHO International Society of Hypertension Guidance also speaks of high normal, roughly systolic BP 130 to 139 and diastolic BP 85 to 89, and considers blood pressure of 140 over 90 or higher to be hypertension.
So why do we care so much? What is the public health significance?
Hypertension is the most common cardiovascular disorder and the leading driver of cardiovascular disease, CVD, worldwide. Untreated, it markedly increases the risk of myocardial infarction, MI, stroke or transient ischemic attack, TIA, and chronic kidney disease. It is called a silent killer because patients may be asymptomatic while target organs, brain, heart, kidney, are quietly getting damaged. Globally, the prevalence has been rising. India has adopted the 25 by 25 goal to reduce premature non-communicable disease mortality, and the India Hypertension Control Initiative aims to accelerate detection and control within primary care.
Let's ground the epidemiology. Types of hypertension?
3 buckets. 1. Primary or essential hypertension, about 93 to 95% of cases, multifactorial, no single secondary cause. 2. Secondary hypertension. Think renal causes like renovascular disease, chronic kidney disease, endocrine causes such as pheochromocytoma, Cushing syndrome, hypo or hyperthyroidism, and drugs including combined oral contraceptives and glucocorticoids. 3. Special populations. Children or adolescents, blood pressure at or above the 95th percentile on repeated measurement. And pregnancy states gestational hypertension, preeclampsia and eclampsia.
Risk factors. Could you split them into modifiable and non-modifiable, exam style?
Modifiable ones are excess body weight, BMI and central adiposity, high sodium intake, low potassium intake, physical inactivity, harmful alcohol use, tobacco, and chronic stress or adverse social environment. Non-modifiable ones are age, notably after 40 years, heredity with polygenic patterns, and certain ethnic susceptibilities. Also remember tracking. Individuals with higher blood pressure in childhood tend to remain on the same trajectory into adulthood.
Quick pause and recall. Name 2 modifiable and 2 non-modifiable risk factors.
Good self-check. And while you pause, keep complications in mind. Target organ damage includes stroke or TIA, heart failure, MI, angina, left ventricular hypertrophy, renal impairment with raised serum creatinine and proteinuria.
Screening and early detection. What should students write and what should they say in Viva?
Start with the why. Hypertension is silent. The US Preventive Services Task Force recommends screening all adults 18 years or older using office blood pressure and confirming out-of-office readings before treatment. That A-grade recommendation was reaffirmed in April 2021. For technique, seat the patient quietly for 5 minutes, back and feet supported, arms supported at heart level, appropriate cuff size with bladder encircling at least 80% of the arm. Use a validated calibrated device. Take at least 2 readings and average them. Avoid caffeine, exercise or smoking 30 minutes prior. Document the arm used. Also remember the rule of halves for control gaps. About half are aware, half of those treated and half of those controlled. Useful to explain community-level challenges.
Let's practice with a case. A 48-year-old shopkeeper attends a health and wellness center for dizziness. His average seated readings at 2 visits are 152 over 94. No diabetes, no kidney disease. How would you proceed?
That's stage 1 by JNC 7 if you go by systolic BP 140 to 159 or diastolic BP 90 to 99. First, confirm with repeat readings, and if available, home or ambulatory monitoring to rule out white coat effect. Assess overall cardiovascular risk, age, smoking, lipids, family history, and look for target organ damage by fundus, creatinine, urine albumin, ECG. Initiate lifestyle measures for all: weight reduction if overweight, dietary sodium restriction to around 3 to 5 grams of salt daily, regular aerobic physical activity, moderation of alcohol, men up to 2 drinks daily, women up to 1 drink, and tobacco cessation counseling. Start a thiazide diuretic as first line in many settings and set a general treatment goal of less than 140/90 millimeters of mercury. If his risk is higher or blood pressure remains uncontrolled, consider adding a second agent.
And if he had chronic kidney disease?
Then we would favor angiotensin-converting enzymes, ACE inhibitors, or angiotensin receptor blockers, ARBs, as renoprotective choices. And many guidelines aim for a tighter control. Individualized targets with comorbidity in mind.
Prevention strategies now. What is the population approach versus the high-risk approach?
Population strategy shifts the entire community distribution towards lower blood pressure. Salt reduction policies, front-of-pack labeling, trans fat elimination, creating walkable environments, and mass media health promotion. High-risk strategy focuses on identifying individuals with raised readings or multiple risks and offering tailored lifestyle advice and, when needed, medication. Both are synergistic.
Students often get asked about the DASH diet. What exactly should they say?
DASH stands for Dietary Approaches to Stop Hypertension. It emphasizes fruits, vegetables, whole grains, low-fat dairy, nuts and legumes, rich in potassium, magnesium and calcium, while limiting saturated fat, refined sugar and excessive sodium. Trials show DASH, especially when combined with sodium restriction, reduces systolic blood pressure by amounts comparable to a single drug in many patients.
Could you outline India's current programmatic response? Because examiners love national program updates.
Absolutely. India's National Program for Prevention and Control of Non-Communicable Diseases, NP-NCD, is the renamed and expanded version of the earlier NP-CD-CS. It adds conditions like chronic kidney disease, chronic obstructive pulmonary disease, asthma, and non-alcoholic fatty liver disease, with service delivery through health and wellness centers under Ayushman Bharat and digital tools like the CPHC NCD app for longitudinal follow-up. Within this umbrella, the India Hypertension Control Initiative focuses on 5 pillars in primary care. 1. Simple, drug and dose-specific standard treatment protocols. 2. Reliable, free drug supply. 3. Patient-centered care with counseling and fixed dose combinations where suitable. 4. Team-based regular follow-up with cohort monitoring. And 5. Information systems for tracking control rates. Early state results, such as from Punjab and Maharashtra, show meaningful improvements in control when these are implemented faithfully.
Nice. Back to management. What are the pharmacologic headlines students must write?
4 key points. 1. Goals. For most adults, less than 140/90 millimeters of mercury, tighter thresholds may be chosen for selected higher-risk groups after weighing benefits and risks. 2. First-line agents. Thiazide diuretics are excellent first-line for many, given evidence, tolerability, and affordability. 3. Combination therapy. Start 2 drugs for stage 2 hypertension or when baseline blood pressure is 20/10 millimeters of mercury above target. Complementary pairs include thiazide with ACE inhibitor or ARB or calcium channel blocker with ACE inhibitor. 4. Comorbid tailoring. Use ACE inhibitors or ARBs in chronic kidney disease. Beta blockers are useful post-MI or when there is heart failure or symptomatic coronary artery disease.
Let us do a second vignette. A 32-year-old primigravida at 32 weeks has new onset blood pressure of 150/96 with pedal edema and 2+ proteinuria. Thoughts?
That is preeclampsia, hypertension in pregnancy with proteinuria after 20 weeks. It needs urgent obstetric assessment, close maternal fetal monitoring, and antihypertensives appropriate to pregnancy, plus evaluation for severe features. Community medicine students should emphasize timely detection at antenatal clinics, referral pathways, and postpartum follow-up because pregnancy-induced hypertension predicts future CVD risk.
Measurement pitfalls. Any quick do's and don'ts to score Viva points?
Do's: remove tight clothing, ensure the cuff bladder covers at least 80% of arm circumference, deflated roughly 2 millimeters of mercury per second, and repeat if readings differ by more than 5. Take standing blood pressure in older adults or those on therapy to assess postural drop. Don'ts: talking during measurement, using too small cuffs, or recording a single reading as diagnosis.
That's a wrap. If this helped you organize your thoughts, subscribe, like, and tell us which community medicine topic you want next. Thanks, Dr. Joshi.
Always a pleasure. Happy revising, everyone.